Okay, well, after some technical errors, I'm very pleased to welcome all our participants here this afternoon to the next in our inaugural lecture series. And this afternoon's inaugural lecture is to be given by Professor Roisin Connolly. And Professor Connolly, we're very pleased to welcome you this afternoon, and we're waiting with bated breath to hear what you have to say. I'd just like to say a few words to introduce Roisin. First of all, my name is Helen Whelton, and I think my video isn't showing on. I'm just getting a message to say I'm not showing. So Roisin, maybe if you stop sharing your screen for a minute. Yeah, I'm not sure. Is that better now? Can you see me? Yeah.
Yeah.
Okay, that's great. Thanks, Roisin. So my name is Professor Helen Whelton. I'm the head of the College of Medicine and Health here in UCC. And some time ago, both myself and Professor Paula O'Leary, who's head of the School of Medicine, engaged with international headhunters to fill the Jerry O'Sullivan Chair in Cancer Research. And we were very pleased to discover Roisin Connolly beavering away there in Johns Hopkins University and Hospital in Baltimore. We had lots of conversations with the O'Sullivan family and with Breakthrough Cancer Research about this post. And I'm really grateful to Breakthrough for the support in filling this really, really important post for cancer research, not just in Cork, but in Ireland and internationally. And Roisin, I know, will be a great lever for change and for development in the region. And in fact, I shouldn't be speaking in the future tense because she's already done that. And I'm sure, indeed, her family must be very proud of her. Roisin, just by way of introduction, went to school in Dublin, into an all-Irish school, Scoil Breda in Ranelagh, and proceeded to Loreto in the Green, where I'd say her secondary education was through English, somehow knowing the Loreto convent as I do. So she did very well in school and made her way to Trinity, where she graduated in medicine in first honours in 2001. Roisin has, Professor O'Leary is going to tell you the rest of her career there, but suffice to say, she excelled at all stages. And her parents, of course, she had the good fortune of having two parents who were secondary school teachers. And her late dad, who we remember today, Ronan, passed away about a year ago. But Ronan was the principal in a school in Tala. And I think both himself and her mum, Olivia, are very proud of Roisin. Roisin is the only medic in her family, and I think probably bears the responsibility then for the whole family's health, if I know what families are like with the medic in their midst. So I was interested when Roisin told me that her dad said, "Oh, Roisin, you're coming back to Cork. Well, they have very good schools there." So he had obviously heard about the quality of secondary education in Cork, which I have to say is very good. So we have Roisin's interests are in traveling. She loves to go hiking with the family and camping. And I know that when she was coming back, I remember in the discussions with Roisin about her return to Ireland, I remember at the time her husband Ian was traveling across the United States, some phenomenal journey with two of the children. So when we say hiking, when we talk about hiking, I think Roisin and Ian see it as a higher level thing than we do. I mean, it's certainly more arduous from my interpretation of hiking, Roisin. So Roisin met her husband Ian when he came back. Ian Barron, qualified in pharmacy from Dublin, and went to the UK and came back from the UK and met Roisin, who was then in fourth year in medicine. And they, of course, went on to do great things together. And they have 3 gorgeous children from all accounts. Owen, who's 13, then there's Afric, Orla, and Oisín, who is 6. So a busy household by all accounts. And really, we're delighted that Ian and Roisin and family have moved back to Cork and that she's taken up her post here. So you're very welcome, Roisin, and I really look forward to hearing your presentation. I'm going to hand over to Professor Paula O'Leary now, who's going to tell people a little bit more about your education after you left Trinity, Roisin. Thank you.
Thank you very much, Helen, and thank you, Roisin. We really do look forward to your presentation today. Helen has told you some of the ways in which Roisin excelled prior to her graduation from the Trinity School of Medicine in Dublin in 2001. But from that time, she forged an absolutely wonderful training career in the area of medical oncology, both here in Ireland and subsequently at Johns Hopkins in Baltimore, USA. Roisin joined the breast and ovarian cancer program faculty at Johns Hopkins in 2011, just 10 years after she qualified, which was a wonderful achievement. So Roisin has worked at Johns Hopkins until she has come to us here in UCC in 2019 at the Sidney Kimmel Comprehensive Cancer Centre, where she was ultimately an associate professor of oncology and co-director of the developmental therapeutics program there. Professor Connolly joined us in September 2019 as the Foundation Professor Gerald O'Sullivan Chair in Cancer Research at UCC. And this is a really important appointment to us here in the university because through Roisin's appointment, we are already reaping benefits and forging links not only internationally and collaboratively with those international stakeholders, but also strengthening links amongst cancer researchers within UCC. And that was one of the primary ambitions of this appointment. And despite the pandemic, Roisin really has worked very hard and very well to build a very strong foundation in that regard. So Roisin's expertise is in the development of biomarkers of response to anti-cancer therapies and the design and conduct of clinical trials that test investigational new drugs in the treatment of patients with both early and late stage cancers. So very early phase cancer research, cutting edge research in the area of clinical treatments for cancer. She has led numerous multi-center clinical trials in collaboration with the Cancer Therapy Evaluation Program at the National Cancer Institute in the United States, the Translational Breast Cancer Research Consortium, and the Eastern Cooperative Oncology Group, Accrual, in the United States. She is study chair for the international phase 3 ECOG Accrual study titled E2112, which investigates the epigenetic agent Entinostat in combination with hormonal therapy in patients with metastatic breast cancer. She recently received the prestigious ECOG Accrual Young Investigator Award in 2019, just prior to her arrival here in Ireland, for excellence in clinical investigation. Since she has come to Cork, as I've alluded to already, Roisin has forged a number of important links with researchers across the university. I don't wish to highlight all of them, but we're particularly pleased to see in the college some very promising research in the area of pilot survivorship funded by a HRB grant in association with Professor Josephine Hegarty at the School of Nursing. And also Roisin has been working on breast cancer biobanking with Leonie Young at the Royal College of Surgeons in Ireland. And it's very important in a relatively small country that we build good and meaningful, strong collaborations with our partner schools, and Roisin is that. She has already published a number of key papers since she has returned to Ireland. She is mentoring and supporting junior faculty in developing their careers. And in addition to all that, Roisin also practices as a clinical medical oncologist consultant at Cork University Hospital, where she is building a busy practice in the area of breast cancer specifically. So she's a very busy person. She's been very successful, and we have great hopes for the future. And welcome to UCC formally, Roisin. I know we've said it a lot of times, but we're really very pleased to have you here. Thank you.
Thanks very much. I'm just going to share my screen, make sure that it's Can I just check if everyone can see that okay?
Yes, we can, Roisin. Thank you.
Great. So thank you so much, Professor Welton and Professor O'Leary, for the very kind introduction. I'm really delighted today to speak this afternoon to such a great audience across the region, and it's a good opportunity for me to be able to, I suppose, celebrate my career to date and achievements, some of which has been mentioned, with a particular focus on the area of translational cancer research, where the ultimate goal is to improve the decisions that we make for patients and ultimately their outcomes. I'd like to just highlight here that my position is a position spanning both UCC and the health service. So this will be the South-Southwest Hospital Group. My practice is in Cork University Hospital, and this has been made possible, this combined position, through the generosity of breakthrough cancer research. And I'll be mentioning that in a little bit more detail later. So I wanted to start off with the first year, which was introduced by our speakers already. And as was mentioned, I started my career in Trinity College Dublin, and Trinity is linked ultimately to St. James's Hospital and Tallaght Hospital in Dublin. So I would have done a lot of my early training from the end of third year medical school in both St. James's and Tallaght Hospital. And one of my first rotations in the end of third year was actually on the oncology service in St. James's Hospital. And that was where I was able to meet some fantastic senior oncologists who have actually both retired now, Professor Peter Daly and Professor John Kennedy, who is shown here on the right. And I think Professor Kennedy in particular has been a great advocate for me during my career from the early days when I noted that I had an interest in following this career path. And so encouraged me to apply for the internal medicine training through the Royal College of Physicians, followed by the higher specialist training as what we call an SBR, or specialist registrar in medical oncology, and ultimately encouraged me also to apply to Johns Hopkins, where both himself and my colleague here in Cork, Seamus O'Reilly, had also trained. And it was in St. James's that I became aware of clinical research and clinical trials, and many of our Irish university hospital sites have clinical trials at them to offer new treatments and new diagnostics to patients. John Kennedy had a big interest in breast cancer, and so ultimately that was the path I went down based on my observations of taking care of those patients and the complexities that were associated with that disease. And so just in terms of a brief introduction to breast cancer and the Irish setting, you know, the majority of my work has been in the breast cancer space, but also, as was mentioned, I've worked in the phase 1 space as well, which would be taking care of patients on early phase clinical trials across cancer types. But for breast cancer specifically, in Ireland, 1 in 10 women will develop breast cancer over their lifetime. And there's over 3,000 women diagnosed annually. So this is a significant national health issue. The good news is that the majority of patients are diagnosed at an early stage, which is curable. We can never forget that 1% of breast cancers occur in men, and all of us who practice have men with breast cancer in our clinic, both in the curable setting, but also, unfortunately, with advanced or metastatic disease. And from a global perspective, this is a huge issue with 500,000 deaths annually from metastatic breast cancer. So I think we have two big challenges. One is making the right treatment choices for patients in the early stage setting to ensure that we're giving the right treatment to the right patient, avoiding excess toxicity, and managing patients in the follow-up period to ensure that they are well supported, that they have minimal symptoms and a good quality of life. And the other big issue is to both prevent and manage metastatic or advanced disease when it occurs. And in Ireland, we have over 700 women every year dying from the disease. And this is data which is from the National Cancer Registry, which we're lucky to have located in close proximity to us here in Cork. But breast cancer is not just one disease. It's broken down simply into three main subtypes, with further characterization being very important in the research setting and may ultimately change practice, such that we're dividing cancer into smaller and smaller subtypes. But the majority of patients that we take care of have what's called hormone receptor positive breast cancer, which is about 2/3 of our breast cancers. And the most important treatment is the hormonal therapy or endocrine therapy, which is blocking estrogen signaling to fuel those cancers. About 15% have HER2 positive breast cancer, which is a particular of interest of mine, and about 15% have triple negative breast cancer, which can be quite difficult to treat, but very responsive to chemotherapy and newer targeted agents. And ultimately, we need to consider both supportive care and clinical trials for every patient at every stage of their disease to try and maximize their treatment outcomes. And so when we're considering research and how we can move forward, we ask ourselves, where can we intervene? And I'm going to focus initially on some experience in the advanced or metastatic stage. Patients can be diagnosed with metastatic disease initially, and then ultimately the cancers become refractory or resistant to treatment. And so this is a big challenge. But the goal in this setting is to prolong life, to improve symptoms and maintain the quality of life for those patients. And so this brings us to the second chapter of moving overseas from a fantastic clinical training in many of our hospitals in Ireland with many great physicians to the opportunity to have a more dedicated path in the research side. And as many of you know, the majority of our oncologists have trained overseas in North America, in the UK and Europe. And we do this to be able to have experiences that we don't currently have here, to see different healthcare systems and really to advance our skills such that we can bring them back. And this is Johns Hopkins here in the city center of Baltimore. We call it the downtown Baltimore campus, where excellence in medicine and surgery aligns with excellence in cancer care. In the middle here, you'll see the Weinberg Cancer Center developed with philanthropic donations. And across the street, the new outpatient building, also funded by philanthropy, which is where I ultimately had my office before moving back here. And then just right across the street, we had what was called the clinical research buildings, which housed both laboratory-based scientists and clinician researchers. And bringing all of these pieces together has given Johns Hopkins a comprehensive cancer center status in the US. And so it's one of many NCI-designated cancer centers in the US. And ultimately, this is an accreditation system predominantly focused on research, which aims to deliver cutting-edge treatment to patients in communities across the US. And I could pick out a number of these where many of my colleagues have trained or are training currently. And these cancer centers are really set up to facilitate translational cancer research, where there are large volumes of patients coming for standard of care treatment, for clinical trials. There are clinicians taking care of these patients full-time. There are clinicians who engage in clinical research and clinical trials. And these are all housed in close vicinity to the laboratory-based researchers, the population health researchers in the School of Public Health, ideally creating an environment whereby we can bring clinical challenges to new research, ultimately to drive improved patient outcomes. And so early on in my time there, for the research component of my training, with my prior interest in breast cancer, I became aware of some exciting work that was going to be happening funded by Stand Up to Cancer, aiming to transition epigenetic therapies from hematological malignancies, where there was a lot of background experience in Hopkins, to the solid tumor space. And so a number of clinical trials were being developed in breast cancer, colorectal cancer, and lung cancer, based on preclinical work from a variety of laboratories in the Cancer Centre and others, including that of Nancy Davidson, who subsequently went to Pittsburgh and now is in Seattle in a series of high-level leadership positions in the cancer space. And Dr. Vered Stearns, who was my primary mentor in the clinical research space, who encouraged me to write my first letter of intent to the NCI to facilitate this clinical trial opening. And this was a clinical trial combining azacitidine, a demethylating agent, with a HDAC inhibitor, Entinostat, in advanced breast cancer. We had additional collaboration at that point with experts in the Cancer Centre in the field of epigenetics, both Cindy Zanow and Stephen Balin. And ultimately, this interaction over time led me to understand really the meaning of the term team science, whereby, again, people of varied backgrounds are sitting together, considering the results from the lab, what was happening in the clinic with the patients, and coming up with new ideas together. Now, ultimately, we looked at both patients with triple negative breast cancer, that small 15% cohort, and the hormone resistant group. And these were patients with advanced breast cancer who had already had prior treatments that were not helping them. Now, ultimately, we saw some signal of activity in the hormone resistant population, but not enough really to call this trial a success in terms of efficacy. However, we did see some interesting changes in tumor biopsies that were taken both pre-starting therapy and after therapy. The triple negative breast cancer cohort of paired biopsies was very small, probably because those patients had early progression. That's a very aggressive disease when it's in the advanced stages. We had more success in the paired biopsies in the hormone resistant cohort. And I will note that patients are very interested in helping with these research biopsies and research correlates, knowing that you're trying to move the field forward. And so we did see, for example, changes in gene expression pre and post therapy. Now, although we anticipated more an upregulation of gene expression in the setting of epigenetic therapy, interestingly, we more saw a downregulation of genes in this small cohort. And ultimately, at the end of my fellowship, an opportunity came up to apply for a faculty position with the breast and ovarian cancer program. And you can see here this large group on the left-hand side. This was one picture of many pictures that we took each year of this group, comprised again of people from very diverse backgrounds. And I was very delighted that so many of my colleagues there were actually international, including from Brazil, from Israel, and from so many other places, which lended to such interesting conversations and opportunities for travel. On the right-hand side, you can see here Nilo Azad, who was my co-director of the Developmental Therapeutics, or Phase 1 program, later in my time at Hopkins. But from early on, I was the breast cancer representative, even from when I was a fellow in the Phase 1 group. So I was constantly engaging with that group, finding out what was going on, and enrolling patients with breast cancer on the Phase 1 trials. And so as we were doing our early combination epigenetic study, we became aware of increasing evidence on the preclinical side that this HDAC inhibitor, Entinostat, might overcome endocrine resistance. And this was work also from Baltimore, from the University of Maryland, but from a different group, from Angela Brody's group, who was an expert in endocrine resistance and preclinical models. And these are letrozole resistant mice. And you can see that slowly over time on the green line, the tumors in the mice were growing. But when you intervened with the HDAC inhibitor, there was inhibition of growth. Either if you stayed on the same hormone therapy, the letrozole in this case, or switched to a different hormone therapy such as exemestane. And these are both aromatase inhibitors that we standardly use as a backbone to treat our patients. The drug Entinostat is from a small company called Syndax, and they sponsored a phase 2 clinical trial called the Encore 301 trial, looking at comparing the exemestane by itself or with placebo versus the exemestane with Entinostat. And this was a phase 2 trial of just over 100 patients. And they did meet their primary endpoint in that there was a small but just about clinically significant improvement in progression-free survival, an important endpoint in breast cancer, but unexpectedly a very large 8-month overall survival advantage as an exploratory objective with this addition. Now, ultimately, these unexpected results led the FDA to designate this combination treatment breakthrough therapy designation, which ultimately that the FDA were happy to speed this through the clinical trial system, such that ultimately, if it was successful, it would be available to patients sooner. And so as we were considering all this data, I had the opportunity to develop the registration trial for this combination because of my involvement with the ECOG-ACRIN group, again, promoted into that group by my colleagues at Hopkins who felt this would be a good opportunity for me. And I worked with mentors external to Hopkins to develop this clinical trial, Joe Sperano, a very prominent breast cancer researcher from New York, and Kathy Miller from Indiana. And they provided high-level senior supervision as this trial was developed, ultimately probably from 2012. And a person who was extremely important from day one with this project was Fengmin Zhao, who is a Harvard biostatistician, who I continue to interact with as we get the publications out and analyze future data sets from this trial. And so what we did in this ultimately international registration trial was that we enrolled patients with advanced breast cancer who had hormone receptor positive disease, that's 2/3 of our patients, who had already had this aromatase inhibitor, but their cancer was growing on this. And we randomized them, as with the phase 2, to exemestane plus Entinostat, the new pill, or exemestane plus placebo. And based on the phase 2 trial showing interesting findings in terms of both progression-free and overall survival, our primary objective for this study was looking at both of these endpoints. And so if either or both were positive, this would be a positive clinical trial. Now, this trial, this graph here highlights our accrual, and just, I suppose, is to explain how complex clinical trial conduct is, how long it can take. And so we activated this trial in March 2014, but had been talking about it for about 2 years before that. Our first patient was enrolled at Hopkins in June 2014. And you could see our anticipated accrual is the orange line, and our actual accrual was the blue line. So very early on, it became clear that we were having issues with accrual. And so we had to intervene. We had to say, first of all, what is the problem? This was not expected based on the numbers that we knew were in the system across the country at these clinical trial sites. But we ultimately found that most likely the problem in inverted commas, was that there was a very active new drug called palbociclib, a CDK inhibitor, which is now standard of care, which was competing for these patients. Patients were looking for trials with this drug. They were trying to access it, and that was diverting them away from our study, which ultimately was the right choice for those patients. But we had significant media input to try and boost accrual. We made some minor changes in our eligibility. And ultimately, although we anticipated that our last patient be enrolled in July 2017, just over 3 years after starting, it was about a year later. But what was important was that we did get to the end. We enrolled all of the patients, and that is very important for us when we're analyzing our results. This is just a shout out to the media and communications team in ECOG-ACRIN who helped me over this time period to ensure that we were promoting the study both amongst the investigators, the sites, and Mary Lou Smith, one of our patient advocates, who has helped me a number of times with various projects, giving us the patient perspective, connecting us with patient groups and channels for promotion of this trial as well. And we even had a video, which you can probably Google, where the team actually videoed me and Hopkins with one of our patients who was quite happy to help to promote the study. And this here is to show that this effort was across the US, involving multiple clinical trials groups, ECOG-ACRIN, Alliance, the NRG, and SWOG, all of whom sit under the NCI National Clinical Trials Network for phase 3 trials. International trial because the University of Pretoria involved from South Africa, We did attempt to get this trial open through Cancer Trials Ireland. That would have been fantastic, but unfortunately there are specific EU regulatory hurdles that prevented that regarding the use of placebo. And these are things that I hope can be overcome with time, especially with our national body, Cancer Trials Ireland, being a voice for change in that regard. Now, after all of this effort, and despite very promising preclinical data and early clinical data in the phase 2, this trial did not show a benefit of adding the Entinostat to placebo. In fact, there was almost a zero difference. Sometimes we see a small difference and we start to say, oh, maybe there's subtypes that might benefit, but really this was a barn door negative trial. And I think it's so important that we acknowledge that we acknowledge the effort that went into this and say that we tried to answer this important question. We hoped that it would provide a new treatment options for patients, but it did not. After all of this effort, this trial was ultimately published this year in the Journal of Clinical Oncology, which is one of our main oncology journals internationally linked to ASCO. And as was mentioned earlier, because of this work that I performed with the team in ECOG Accrual, I was very, very honored to receive what is called the Young Investigator Award in 2019. And really this is to honor people who put a lot of effort into clinical research excellence within the group, and is open to anyone under the age of 46, which I'm glad to say I'm still under that cutoff. And shortly after starting my position in Cork, I had the opportunity pre-pandemic to fly to Florida to give a presentation about my work, and I'm delighted to have had this opportunity. And so for the last portion of the talk in regards to advanced breast cancer, I wanted to just mention this study that was just presented on Friday by one of my colleagues, Dr. Roussos Torres, who's currently in USC on the west coast of the US. And again, this shows the importance of interactions between different disciplines, between different research groups within and outside an institution. And so Hopkins has significant expertise in the areas of epigenetics, but also immunotherapy. And in discussions between colleagues, it was noted that a number of patients who were enrolling in some of the early immune checkpoint inhibitor trials who had previously received epigenetic therapy on a clinical trial, because again, these were areas of great interest to the Cancer Centre, that these patients getting immune checkpoint inhibitors may have been doing slightly better than expected. And then it was hypothesized, could the epigenetic therapy that they've previously received possibly be sensitizing their cancers to the immune checkpoint inhibitors and making them respond in a more effective way than they would have anticipated. And so this prompted a lot of new preclinical work in this space, both within and outside Hopkins. And ultimately, again, with the robustness of the preclinical data, we developed a phase 1 clinical trial, which we led through the Experimental Therapeutics Clinical Trial Network, which is the NCI network focusing on early phase studies, being that phase 1 and phase 2. And so this clinical trial, led by myself and my colleagues at Hopkins, was also open at Pittsburgh, at Yale, and at the City of Hope in the West Coast. And this presentation just on Friday evening, sort of broadcast from Paris, was related to the advanced breast cancer cohort of this. And Torres very nicely outlined the background to this. Immune checkpoint inhibitors are approved currently, but not available, many of them in Ireland, for early and late stage triple negative breast cancer. But not every patient responds to these treatments. And so there's a lot of effort to see how can we improve the efficacy of these agents, which can really impact patient outcome in terms of long-term disease control, and it seems cure in a small cohort of patients. And preclinical models in breast cancer and pancreas cancer were showing that this HDAC inhibitor Entinostat appeared to improve the efficacy of the immune checkpoint inhibitors and was associated with increase in CD8 positive effector to FOXP3 regulatory T cell ratios, possibly considering a mechanism for how they might be working. And we published earlier this year the phase 1 dose escalation portion of this study, which identified the dose that would move forward into subsequent studies. We identified an overall response rate or tumor shrinkage of 16% in patients who were not necessarily expected to respond to these agents, and did see these increases in the T-cell ratios in the patient biopsies, again, pre and post therapy. And this is the schema here for the breast cancer cohort. These patients had not previously received immune checkpoint inhibitors, and they had biopsies and blood sampling performed before and after a 2-week run-in of the HDAC inhibitor to try and tease out maybe differences in the biology or resistance mechanisms for the HDAC inhibitor alone in advance of adding the immune checkpoint inhibitor. This presentation was a small cohort of 24 patients. So again, phase 1 and phase 2 trials more commonly look at smaller cohorts versus the phase 3 trials where we had the 600 patients in the E2112 study. And we enrolled about 50% hormone receptor positive and 50% triple negative patients. The toxicities that were seen were what we understand from the literature and from the clinical care of patients receiving some of these drugs. Many of my colleagues here in Cork are very expert in using the combination of nivolumab and ipilimumab, for example, in diseases like melanoma, and have become very familiar in managing these toxicities and the immune-related toxicities that are associated with them. And in this cohort, we saw an overall response rate of 30%. And when you broke that down, which we probably shouldn't do, but in the triple negative breast cancer cohort, the response rate was more like 40%. And you can see here a waterfall plot with the blue indicating triple negative breast cancer. The 30% line here is the shrinkage of the cancers on imaging as determined by our radiologists. And when we go below the 30% shrinkage in a clinical trial, that's called a response in terms of either a partial response or, as in this case here, where there was 100% shrinkage of the cancer, that's called a complete response. And the spider plot on the right-hand side indicates, again, under the 30% line, and those patients who have the response, with some of them lasting out many, many months, especially in the triple negative group. And that is our hope, that we can identify patients who can do very well with these treatments and possibly have disease control for many years, if not long-term, as we have seen in some of the other cancers. From a correlative science perspective, there's a lot of correlative science going on right now with the blood samples and the tissue samples from this trial, mainly being driven by the lab of Elizabeth Jaffe and Johns Hopkins, with support from both myself and Dr. Torres now on the West Coast. And essentially, there were some changes seen in the median CD8 to FOXP3 ratios. And the thought is that perhaps the epigenetic therapy is increasing the CD8 density, which is felt to be a T cell that might be necessary for the immune checkpoint inhibitors to work. And so at the moment, we're planning a next step trial. We're designing a randomized clinical trial to tease out further the benefit of this combination in patients with breast cancer. We cannot tell too much about benefit from an early phase clinical trial. And so the next step would be a randomized clinical trial, which will likely be driven again through the NCTN. My hope is that because Ireland is a clinical trial site for the NCI through Cancer Trials Ireland, our national network, that as well as being able to open many of the phase 3 studies here, that we may also be able to open some of these earlier phase studies driven by our own ideas and our own collaborations, making these treatments available to our patients. And so if I just move tack a little bit to the early breast cancer space, another area of interest of mine, particularly HER2 positive breast cancer in this space, where the goal really is cure. And if we pick things up early enough through mammogram and picking up precancerous lesions, we can also prevent the cancer from developing, and also maintenance of quality of life. And just very briefly, in terms of early breast cancer management, this is the conversation that we have every week in our multidisciplinary meeting in CUH. and across the country, where surgeons, radiation oncologists, medical oncologists, pathologists, radiologists, plastic surgeons come together to discuss the optimal management of each individual patient. In some cases where the cancer is large, we might consider what we call neoadjuvant or pre-surgical treatment to shrink down the cancer, make it easier to remove, and possibly provide some prognostic information for that patient. We can sometimes consider adjuvant therapy with surgery first, and then we have patients in a follow-up phase where we basically are keeping an eye on them for a period of at least 5 years to try and pick up any problems that arise. And so HER2 positive breast cancer in the past was quite a devastating diagnosis in that patients relapsed very frequently. But with modern pathology and with preclinical studies identifying a target for HER2, this has become a very, very treatable disease. And the earliest clinical trial back in 2005, one of a series of clinical trials, highlighted that if we add a HER2-directed therapy, a monoclonal antibody trastuzumab, to chemotherapy, that we can really prevent recurrences in a large portion of patients. This is probably one of the more striking curves that you will see in cancer clinical trials. And ultimately, although this is disease-free survival, ultimately overall survival advantages were also observed with this treatment approach. And over the last decade, there have been a plethora of new treatments targeting HER2, mainly adding to HER2, or mainly adding to trastuzumab, such as pertuzumab, but also potentially replacing it. And we have new antibody drug conjugates that we can give after surgery for patients with residual disease. And so over the last decade, there's really been a shift in escalating treatment and adding and trying to get more and more shrinkage for those cancers pre-surgically. And so we have all of these new treatments that have maximized efficacy in many cases. And there's an estimate that, for example, the 3-year disease-free survival can be as close to 95% with these modern regimens. And so the question has arisen, do we need to continue focus on pushing up the treatment intensity with its associated toxicity, or can we now start to pull back a little bit and try to individualize the treatment, because we know that not every patient needs the aggressive approach that is associated with significant side effects, which many of you will be aware of: hair loss, sickness, low blood counts, infection, and sometimes even ICU stays. And so there's a big interest in the area of biomarkers of response and resistance to HER2 therapy. And these biomarkers can be in the form of blood-based biomarkers, tissue-based biomarkers, which is where a tumor biopsy is taken, and imaging-based biomarkers is of increasing interest. And this image here on the right from Alex Prat and colleagues in Barcelona indicates that more and more, again, we are thinking of HER2 positive breast cancer subdivided further and further, with the HER2 intrinsic subtype by gene expression profiling possibly being the subtype that is most sensitive to these treatments and might be the space within which we can de-escalate our treatment. On the bottom panel is the increasing number of clinical trials using imaging-based biomarkers in HER2 positive breast cancer, with the TBCRC 026 trial led by myself and colleagues. And this is here indicating this study where our question really was, can we actually ultimately down the line omit chemotherapy in a portion of these patients? And this was a clinical trial developed with the support of the Conquer Cancer Foundation of ASCO, the Translational Breast Cancer Research Consortium, and 9 associated clinical trial sites that participated. There was significant funding from pharma for this study as well, and Richard Wall would have been a very senior nuclear medicine expert who helped with the design of this trial in regards to the PET aspects. And ultimately what we found was that if you can do a PET scan as early as 2 weeks post-starting HER2-directed therapy, you can tell who will not get a pathological complete response or complete shrinkage of the cancer with HER2 therapy alone. And so that's picking out the resistant population. And this here shows the day 15 time point, and basically those who had a decline in their SUV on the PET scan to 3 and below were very likely to have a PCR, and those with a 40% decline from baseline to day 15 were also likely to have a PCR. And this is just showing the ROC curves. And the most important biomarker result from this trial was the negative predictive value, which was in the 90s, which suggested that really we could predict most relevantly those patients who would not obtain that complete shrinkage at the time of surgery with this early biomarker. And so because of these promising results and because of a great interest of imaging biomarkers within ECOG Accrual, I'm working with two imaging collaborators, Heather G. Seen at the Dana-Farber and Dave Mankoff, as well as one of the imaging-specific biostatisticians, Konstantin Gatsonis, to develop a larger trial to validate this biomarker in HER2 neoadjuvant space. And this is called the DIRECT trial. And ultimately, we hope that it will facilitate escalation and de-escalation of this treatment approach, ultimately down the line showing clinical utility where we can change practice and make the treatment decisions better for patients. So that was related to maybe pulling back on treatments, trying to find ways to do that. But we do know that there is the space still for finding better treatments because some patients do have the cancer come back despite our best treatments. And there are some very interesting drugs coming on the market now, including trastuzumab deruxtecan, another antibody drug conjugate with a topo-1 inhibitor payload, which is delivered then directly to the cancer cells after internalization. And this has really shown dramatic results in breast cancer, lung cancer, and gastric cancer, both tumors that are HER2 positive by standard criteria, but also HER2 low. And there was some recent updates presented at the ESMO meeting this weekend, highlighting really practice-changing results in the metastatic space. We are hoping to open 2 trials in COH in the next month or 2 with this drug, the Destiny-05 trial in the early space and the Destiny-12 trial in the metastatic space. And so really it's so important for us to be able to access these trials, to get them through our regulatory systems quickly and get them open so we can provide these options for patients. And so ultimately, I think the future is that we are tailoring therapy to the individual and all the way from no treatment for some patients to the more aggressive approaches. And so the last chapter in the last few slides, well, the third chapter, who knows what the future holds, is the move here to Cork. And I am so honored to be taking this position, which is to fulfill the legacy of Professor Gerald O'Sullivan. And as I mentioned earlier, this position has been supported by Breakthrough Cancer Research. I never had the opportunity to meet Professor O'Sullivan, but I've heard so many things about him over the years. Unfortunately, he passed away in 2012, but had qualified from UCC originally in the 1960s and had surgical training both in Cork, in Dublin, in the UK, and in North America before returning to the Mercy University Hospital in 1985. And in 1999, he had a fantastic reputation as a wonderful surgeon and clinician who focused on his patients and the optimal care for his patients, but had a very inquiring mind on the research side, and ultimately set up a cancer research centre in Cork in 1999, which ultimately moved to the Western Gateway space where I'm sitting now. And this previously was the Cork Cancer Research Centre and has been renamed as Cancer Research at UCC. And this is where, based on his interest in interfacing clinicians, clinical researchers, clinical trialists with laboratory-based researchers and having people sitting side by side to discuss the challenges and to develop new ideas, new research projects, and ultimately treatments and diagnostics that would help patients. And so I hope moving forward to expand on what he has built. And I am so delighted that there is a real desire to integrate here in Cork. And this is a slide that I have previously borrowed from Professor Welton, where it is so important for us to have an academic healthcare system here where we're integrating the best of our healthcare system with the research expertise in the universities, and that close partnership is so critical to have a world-class service, to develop professional talent, and ultimately, again, to impact outcomes for our patients in this region with a very large catchment. And so how do we impact patient outcome? And I feel that we have a fantastic base here. We have so much great science here, so much great research going on in terms of data, population health, survivorship, cancer biology. In the School of Pharmacy, we have fantastic researchers in the cancer research at UCC space, spanning autophagy and microbiome. We have the APC, World Leading Institute in Microbiome, and the Tyndall Institute, all within this space. And this is only naming the ones that can fit on the slide. So ultimately, I think we have a fantastic base here. And the question is, you know, can we continue? Can I continue? Can my team continue to tailor therapy to the individual, to develop clinical trials that are going to improve patients' outcome? And this is the whole field of precision oncology. And this slide here is just giving examples of the many types of clinical trials that we can develop to try and improve patient outcomes. And I believe that we do have the platform here. We're very lucky that we have a national network, Cancer Trials Ireland. One of my colleagues, Professor O'Reilly, has a leadership position now within this organisation, which is fantastic. I myself am a member and co-chair of the breast disease specific group of Cancer Trials Ireland. And this gives us the opportunity to attract the best research and the best clinical trials to Ireland for our patients, spanning pharma, academic, international groups, and giving us a platform to develop our own homegrown ideas. And I'm also delighted to say that the activity on the clinical research side, on the cancer trial side, is for the last number of years, the best here in Cork in the country. And you can see here some of our research teams, our clinical trials units, both in the Glandor space and COH on the left, and in the Bon Secours on the right, who have worked together for over a decade to bring these trials to our patients, with our main activity being in the breast cancer space, the hematology space, the GU space, and gynecology, amongst others. We do cater to all cancer types here in Cork because our cancer centre caters to every disease. And we have been given another opportunity recently to expand further. And we are now, in the very near future, there will be an announcement from the HRB for funding that is coming in to support new cancer trials groups. And we have proposed a UCC Cancer Trials group that is now moving from Cork City to also include our partners in Waterford. And the main goal of this new system is to try and improve access to clinical trials and bring us to the national benchmark outlined by the National Cancer Strategy of 6% accrual of new patients to clinical trials, which seems quite low. In the US, it's 10%. And so we feel here that we can really get to 6% and beyond over the coming 5 years with this new partnership, which spans the HSC, UCC, and the HRB. Another big goal of ours is to facilitate the homegrown investigator-initiated clinical trials. And here are just a number of my colleagues who are actively engaged in clinical research, who have both local, national, and international collaborations in this space. And we hope in the near future to be attracting 2 more academic oncologists in the medical oncology space to Cork to help boost the availability of new ideas and new people to drive this agenda. We also have an incoming chair of radiation oncology, and we have new hematology colleagues joining us soon. So the future is very bright. I just wanted to highlight again that we can work locally, and I've been very lucky to have a new collaboration with Josephine Hegarty in the School of Nursing and Midwifery for a new pilot project supporting women with breast and gynae cancer after their diagnosis. And this is an Irish Cancer Society sponsored initiative. We have also been lucky to receive support for cancer research for this team, which is providing a specific intervention to try and improve symptoms and quality of life for our patients. And this trial has been developed in collaboration with the CRF and the Patient Focused Research Committee in UCC, which we are going to be working with more and more as we move forward and expand our efforts. We want to not only work locally, but also nationally. And I'm delighted that with the emerging virtual All Ireland Cancer Research Initiative, that more and more people are keen to work as networks to work collaboratively. And this is just one example of a national collaboration between RCSI and UCC and CUH. Professor Leonie Young has a breast cancer biobank, and I have a sub-study developed now within this to look at the blood of patients who have completed their neoadjuvant HER2 therapy to try and see, can we identify minimal residual disease in these patients, at which time point perhaps we could intervene with a new therapy like TDM1 or the trastuzumab deruxtecan to try and prevent their cancer from recurring. And I'm very grateful to Paul Redmond for his collaboration in this regard as well. So we have local, national, and we also have a lot of international collaborations we want to expand on. And this is just a few examples of groups which my colleagues, both in Cork and Waterford, have leadership positions within: the Breast International Group, NGOT, the Gynae Group. And we have developed a new collaboration locally here with CUH, with SALTI, which would be, I think, the equivalent in Europe for the Translational Breast Cancer Research Consortium. This is a Barcelona-based group who do translational breast cancer research, and we're delighted to be partnering with them in the very near future. So where do we go from here? I think with this expanse of research in the university, the clinical trial system that's expanding, we want to see how do we get to the next level. And many of our colleagues in centres in Europe, such as the Institut Curie in Paris, the Jules Bordet in Belgium, the Christie in the UK, and more recently our colleagues in Trinity have gone through an accreditation process to foster high quality comprehensive cancer research, education and care combined in one package as a comprehensive cancer centre. And Trinity have obviously seen the benefit of bringing the science from Trinity together with the research happening in the hospitals and the care of patients, and they have their OECI designation at the end of 2019, and so we will congratulate them for that. And this fits very much in line with the European Cancer Mission and the Europe Beating Cancer Plan, which is focused on supporting focused infrastructure to ensure quality care, which both the National Cancer Strategy and others, including our European colleagues, feel it's essential to integrate the clinical care with the research for optimal output and optimal patient care. And so I'm finishing here, and I just want to remind myself and all of us that it is the patient that's at the center. This is a picture of one of my patients in Baltimore who was quite happy for me to share this, a wonderful young woman who was a single mother of 3 boys, holding down a job and going to school afterwards in the evenings to try and provide the best opportunity for herself and her children. And she had HER2 positive breast cancer and struggled with the side effects of treatment. And she inspires me when I think of her and when I look at this picture, because that is what we should be aiming for, is to again help patients to have a better quality of life and a better outcome through our research. So thank you so much for your time.
Thank you, Roisin. You could unshare your video now, if you would mind. I just want to say, Roisin, you're a pioneer and a research pioneer, and everything you're doing here, you're doing in such a fantastic way. Professor Jerry O'Sullivan himself was a pioneer, and I think he would be very pleased with not only with what you've done already, but with the plans you have shared with us. And I'd just like to take the opportunity to thank you for your vision, for your leadership, and for your generosity. You have shared with us a very ambitious vision for cancer research in this region, and I think it will help to lift cancer research in Ireland and internationally as well. And this will provide a tremendous, I suppose, ecosystem for us to develop the next generation of healthcare workers and healthcare leaders. And so the ripple effect goes on. It'll provide a tremendous environment for them to train and for their ambition, but also it will be really important in terms of patient benefit, as you have shown us and as you have illustrated so excellently and so clearly in your presentation. I can see the teacher-parents effect coming out there in that lovely, clear presentation, which I thoroughly enjoyed. Thank you. It was just, you explained it all in a very accessible way. So it remains for me to thank you, to express my delight in the fact that you are just supporting such a major part of our strategy to further develop research for patient benefit. And at this point, I'd also like to acknowledge your colleagues who in the South-Southwest Hospital Group and CUH in particular, and the Mercy at the South Infirmary, who have been so supportive of your appointment and in facilitating the very important research that you're doing. So well done on everything you've done. You've done so much in terms of leadership already, in terms of leading research grant applications, in developing that wonderful vision for a comprehensive cancer centre here. And I truly look forward to working with you in the future and helping you to develop this vision. So I see there's some comments in the chat. So we have wild applause coming from Darren Daly and from Bojan Mankovic, who's a world class. Everybody's clearly delighted. So 2 questions from Liam Fanning. Can you outline the ethics of using placebo-controlled trials? You mentioned at the beginning of your talk, and do you see a place for mRNA vaccines in cancer management? So first of all, Liam just had a question about the ethics of placebo-controlled trials. If you just want to say a word about that.
Yeah, that's a great question. And I suppose whenever we are considering a randomized trial, we consider what is the standard of care at the time when the trial is designed. And then we have to make sure that there is treatment equipoise. So we cannot have a situation whereby a patient or a physician feels uncomfortable going on to a clinical trial. And so the standard arm needs to be a very reasonable option. So when my clinical trial was designed in the early days, single agent endocrine therapy was a standard of care that was being used. Subsequent to that, we have had this explosion in a new therapy called the CDK inhibitors. And so if I was to design that clinical trial now, the comparator would likely have to be the CDK inhibitor as the standard of care versus the interesting drug.
Yeah.
And in relation to the mRNA vaccines, I mean, I think that there has been, a huge amount of interest in vaccine research in the cancer space. We have significant expertise in UCC with vaccine development. And I think for sure, anything that is going to sort of activate the immune system to fight the cancer is going to be of interest. And so hugely supportive of anything along those lines to try and improve patient outcomes. Yeah.
Great. So Roisin, and other great plaudits coming in there, so you can enjoy those later. So I'd like to thank you and to thank everybody for tuning in. We'd normally be going for a cup of tea now and a chat, but hopefully we'll get a chance to do that in real life. But thank you so much. Excellent presentation. And again, many thanks to everybody for tuning in today. Thank you.
And thank you so much, and for all the support of everybody. I see so many friendly faces on the chat, and thank you, as Helen said, for every bit of support that I've received since coming here, both from the hospital side and the university side, and all of the support services nearby, charities, and especially Breakthrough and our cancer care services. So everyone has been fantastic.
Okay, thank you. Thanks, everybody.
Thank you.
Bye.